Welcome to this presentation on the management of post-carotid endarterectomy neck hematoma. This talk will focus on the recognition and practical management of this scenario, particularly from the perspective of the first responders. These are often ward teams, anesthetists, and vascular surgeons who are called when deterioration occurs. These guidelines are not intended to represent a minimum standard of practice, nor are they to be regarded as a substitute for good clinical judgment. They present key principles and suggested strategies for preparation, performance, consent, and training to inform clinical practice. This document is intended to guide appropriately trained operators. The incidence of post-carotid endarterectomy neck hematoma is quoted between approximately 1 to 12%, whilst the incidence requiring re-exploration is approximately 1 to 3%. Although uncommon, the consequences can be severe. An expanding hematoma can compress the airway and distort anatomy, making airway management progressively more difficult. Airway compromise can deteriorate swiftly, leaving minimal time for planning or mobilizing senior help. Without expedient, effective management, patients face a significant risk of fatal or disabling cerebral and cardiac hypoxia. For this reason, early recognition and clear team coordination are critical. Airway compromise in this setting is largely driven by venous obstruction within the confined anatomical space of the neck. As the hematoma expands, venous and lymphatic drainage from the larynx becomes impaired, leading to progressive laryngeal edema. This edema can significantly narrow the airway even before external swelling becomes pronounced. Consequently, the severity of airway compromise may not always correlate with the visible size of the neck swelling. Mild voice change or hoarseness is not uncommon following carotid endarterectomy and may reflect minor postoperative swelling. However, worsening voice change, progressive hoarseness, or the development of swallowing difficulty should prompt early senior review. To facilitate recognition, airway symptoms can be broadly categorized into urgent and life-threatening features. Urgent symptoms can be remembered using the acronym CHAD: change in voice, worsening hoarseness, anxiety, difficulty swallowing, and discomfort or pain. These symptoms suggest evolving airway compromise and require urgent senior assessment. More concerning are the life-threatening symptoms summarized by the acronym SATS: salivation or drooling, agitation, tracheal deviation, tachypnea or breathing difficulty, and stridor. Stridor in particular is a late sign suggesting impending airway obstruction and is associated with a high chance of failed airway management even following neck hematoma decompression. The presence of any SAT symptoms should be treated as an airway emergency, and a 2222 call should be triggered immediately. While definitive management is being organized, several temporizing measures can help stabilize the patient. First, call for help early, ensuring both anesthetic and surgical teams are involved. The patient should be sat upright, which may help reduce airway obstruction. Administer 100% oxygen, ideally using high-flow nasal oxygen if available. Blood pressure should also be controlled, with the target systolic pressure being less than 160 millimeters of mercury. Finally, it is important to locate the neck hematoma box and e-phonar kit early, as these may be required urgently. Once initial stabilization has occurred, further management is guided by a critical clinical question: how much time do we have before airway compromise becomes critical? The degree of urgency determines the airway strategy and the timing of surgical intervention. For practical purposes, this can be conceptualized as 3 pathways: no time, some time, or adequate time. Patients with SATS features fall into the no time category. These represent life-threatening airway symptoms and should be treated as an immediate airway emergency requiring rapid escalation and intervention. Patients with CHAD symptoms fall into the sometime category. These features indicate evolving airway compromise and require urgent senior assessment and preparation for airway management. Finally, patients with adequate time have no airway symptoms other than a minor and stable change in voice or hoarseness. These patients require close monitoring as deterioration may still occur. This figure outlines the first responder approach to a suspected postoperative neck hematoma following carotid endarterectomy. Initial management is the same for all patients. The patient should be positioned upright, high flow oxygen administered, and blood pressure controlled with a target systolic pressure below 160 millimeters of mercury. The next step is to assess whether airway symptoms are present and determine their severity. Patients with no airway symptoms other than a minor and stable change in voice require close monitoring and early senior review while preparations are being made for potential escalation. It's important to locate the neck hematoma box and e-phonar kit. These patients require 1 hourly observations, and it's important to consider moving them to HDU or theatre recovery for this purpose. It's also important to prepare for a potential transfer to theatre. Patients with urgent symptoms described by the CHAD mnemonic require immediate escalation to both anesthetic and vascular teams and an urgent assessment by them. Here again, it's important to locate the neck hematoma box and e-phonar kit. These patients often require their neck wound being opened in the ward before being transferred to theatre for further management. Patients with life-threatening symptoms captured by the SATS mnemonic represent an airway emergency. In this situation, immediate activation of the emergency response system is required. The neck wound should be opened without delay to decompress the hematoma, and the team must be prepared for emergency airway management, including front of neck airway access if required. This figure focuses on the anesthetic management of airway compromise following carotid endarterectomy once the emergency has been recognized and initial stabilization measures have been initiated. The airway strategy is guided primarily by the degree of urgency and the time available before airway compromise becomes critical. In patients with adequate time, where airway symptoms are minimal and the patients remain cooperative, there is an opportunity to plan a controlled airway strategy. In this setting, awake tracheal intubation should be strongly considered, allowing airway control while maintaining spontaneous ventilation. When patients fall into the sometime category, airway compromise is evolving. Following decompression of the hematoma, airway management may proceed under general anesthesia with videolaryngoscopy as the primary technique and a preloaded bougie or stylet to maximize first pass success. A supraglottic airway may serve as a rescue device if initial intubation attempts fail. In the no time scenario, patients present with severe airway compromise or peri-arrest physiology. In this situation, attempts at conventional airway management may be unsafe, and clinicians must be prepared to proceed rapidly to emergency front of neck access, most commonly via surgical cricothyroidotomy. Across all scenarios, maintaining oxygenation, anticipating rapid deterioration, and ensuring early collaboration between anesthetic and surgical teams are central to safe management. The SCOOP protocol is well established in the management of post-operative neck hematoma following thyroid and parathyroid surgery, where it provides a structured approach to emergency wound decompression. However, this protocol cannot be directly extrapolated to carotid endarterectomy. The surgical field, anatomical structures, and associated risks differ significantly, because of which there is a need for a tailored approach specific to carotid endarterectomy. In response to this, we have developed a modified SCOOP protocol specifically for post-carotid endarterectomy neck hematoma. This protocol is designed to support first responders in a time-critical situation, providing a clear stepwise approach to wound decompression in the presence of airway compromise. The indications for activation remain the same. Patients with urgent or life-threatening airway symptoms, as described by the CHAD and the SATS criteria, require immediate consideration of wound opening. The following slides outline each step of the SCOOP approach in sequence. The first step is to remove or strip the neck dressing. The next step is to cut the skin sutures. This releases the superficial layer of closure and may allow partial decompression of the hematoma. The next step is to gently insert a finger into the wound. This is an important step in facilitating more effective opening of the wound after the skin sutures have been removed. The next step is to open the platysmal layer. This is typically performed using a blade to divide the sutures holding the platysma together. It is a critical step as significant pressure may persist if only the skin has been opened. Adequate release of the platysma allows more complete decompression of the hematoma and helps relieve ongoing airway compromise. Once the layers have been opened, the wound should be actively opened and spread out. This facilitates evacuation of clot and allows more effective decompression of the neck structures. The final step is to pack the wound. Packing helps tamponade bleeding while maintaining decompression of the hematoma. This is a temporizing measure, allowing time for definitive surgical management while reducing the risk of reaccumulation. In summary, the management of post-carotid endarterectomy neck hematoma requires a coordinated and structured approach. Initial recognition and escalation are guided by the first responder framework, followed by an anesthetic strategy based on the urgency of airway compromise. The SCOOP protocol provides a clear and practical method for emergency wound decompression when airway compromise is present. Together, these approaches provide a clear and practical framework for managing this emergency, helping teams act quickly and work effectively to improve patient safety. Thank you.